I like to present you the recent results of infections due to contaminated duodenoscopes in gastroenterology. So there was a dogma in the past that strict adherence to the reprocessing protocol can prevent any transmission of viable organisms from one patient to the other or from patients to the environment. But in the last 5 years, there were several series about tremendous infections transmitted by duodenoscopes. And the whole story started with the carbapenem-resistant New Delhi metallolactamase Escherichia coli in Chicago. This germ was transmitted by an American traveler, and it infected 39 patients after an ERCP. And in the following years, data came from Germany, from France, from America again, and from the Netherlands. The most exciting story came from Seattle, where 32 patients were infected and 16 died, mostly due to their tumor metastatic disease, but in some cases there was a discussion about the relation to the infected with multi-resistant germs. The study of Rotterdam was analyzed in detail. Here, Pseudomonas aeruginosa was the specific germ that infected 30 patients in following series. And in the analysis, it was found that the distal end of the duodenoscope was the crucial part for infection, in particular the area behind the Albarin elevator. There was a difference between two types of endoscopes of the Olympus company. In the former type, the elevator wire channel was opened and allowed rinsing and flushing of the specific channel. In the new model, the distal end had not a removable but a fixed cap, and the channel was closed. And in contrast to the former construction, the area of the Albarin elevator was hardly to brush with the normal brush that was used at this time. Though this area behind the Albarin Hebel and the area behind the optic lens, where the parts where bacteria were found. So all these series had some common features. First, there were only lateral viewing endoscopes concerned. And for the first time, multi-tract resistant bacteria, all belonging to class 4, were found. That means carbapenem resistance and no antibiotics will work. Finally, endoscope reprocessing was proved without any breaches of the reprocessing protocol, but in further analysis with the manufacturer, some micro damages were found on the distal instruments, allowing a bacterial adherence and the formation of biofilms. Most infections came in fact from the States, and most were detected by the national authorities for infection control or by local authorities, but not by the endoscopic service itself. So in fact, the human gut is the reservoir for these bacteria. There are gram-positive and gram-negative bacteria that can be responsible for these infections, but moreover, they are the dangerous gram-negative, and in particular, the Enterobacteriaceae with Klebsiella pneumoniae, Escherichia coli, and Enterobacter species. The carbapenem-resistant superbugs are the bacterial group which was mainly concerned. Among all antibiotics that work in the human body, penicillins, cephalosporins, and fluoroquinolones are normally able to kill the bacteria. Only if a fourth group, the carbapenem, will be unable to kill bacteria, then there is no further choice for a specific treatment. Though in the MRGN system, all these reactions are listed, and bacteria belonging to the MRGN3 group, they have a small part that can also work, that is the carbapenem antibiotics. In the MRGN4 group, there is no further antibiotics that can work. And these germs still have the capacity to inactivate by their enzymes the antibiotics by beta-lactamases and carbapenemases. Another point was interesting coming from a large series from Los Angeles, from University of California. Here they analyzed the risk factors for infection, and that was stent implantation in patients with malignant biliary disease, those with cholangiocarcinoma, and moreover hospitalized patients in contrast to outpatients. And another point was interesting, the long time before such an infection came apparent. In this retrospective analysis of Los Angeles, the source of infection was found in October 2014, and the infection became apparent in February 2015, where the total number of patients exposed were 115. Finally, 15 in the follow-up acquired the CIE, and an active infection was found in 8, and those who were colonized were further 7. So what is now the problem of hygiene and infection in endoscopy, where we believed we can have a very strong procedure and a strong reprocessing protocol? And what are the lessons, not the lesion, the lessons and consequences from these series of contaminated endoscopes? There are some fatalistic words coming from Rutela, a microbiologist from the States and one of the main opinion leaders. He said, if the margin of safety is so small that perfection is required, then the design of endoscopes is too complex and the process is too unforgiving to be practical in a real-world setting. In other words, our way of reprocessing doesn't work. And the little bit less dramatic Lars Årbakken from Norway stated, for a long time to come, we will have to accept that completely bug-free instruments remain an illusion. So let's see what we can do to overcome this problem. So let's start with the basics. Endoscopes belong to semi-critical devices following the Spalding classifications. Flexible endoscopes and its components have to undergo a long and detailed process for preparing, starting with manual cleaning, the automated reprocessing in a washer disinfector, and finally a rough drying before storage. Endoscopes are thermolabile and therefore they cannot be sterilized. Sterilization means complete destruction of microorganisms, including bacterial spores. And all the attempts to use these procedures to flexible endoscopes have failed. So steam autoclave isn't possible by these high temperatures. Ethylene oxide gas doesn't work completely. So disinfection, meticulous disinfection is demanded. And that will reduce the number of viral organisms on a device by irreversible destruction to a level which seems to be appropriate to safe use on a patient. And that may include all microbiological pathogenous bacteria, mycobacteria, virus, and fungi, but not necessarily all spores. Let's look to the reprocessing process. So it has 6 steps for disinfection. And looking at the end of this slide, what it will work. Usually, the bacterial load of a colonoscope will have 8 to 10 log steps. The elimination rate, in contrast, is 8 to 12. So the safety margin is extremely low, between 0 and 2 log steps, demanded that the whole process is exactly working. It is divided in 3 main steps: the manual cleaning, the bedside cleaning before in the endoscopy room, followed by manual cleaning in the reprocessing area by extensive brushing, the process in the automatic washer disinfector with rinsing, disinfection, and final rinsing excluded from human handling, and the manual act at the end, transport and storage to the endoscope cabinet. It has to be kept in mind that endoscope design is very complex. Not only it is a thermo-labile instrument, but it has also small, narrow lumina and branched channels. And the ERCP instrument, the duodenoscope, at the very end, also very complex design in and around the Albaran elevator. So looking to the small channels, we have another problem. The problem is the formation of a biofilm. Biofilm contains residual organic material, moreover protein plugs. And moisture in small channel will allow the bacterial adherence, and a bacterial cell division occurs every 20 to 30 minutes after the process. So today we are convinced that the cleaning step is the most important, and brushing is demanded several times not to allow the adherence of bacterial masses within the small channels. If this process fails, then the bacterial, which are formerly planktonic, that means they are not adherent, cannot be killed because they cover themselves with mucopolysaccharides, and they form the biofilm within the channels, in particular in small scratches and uneven surfaces. And then they are much less susceptible to any disinfectant. In the last digestive week, for the first time, it was demonstrated by a video camera, a very small one which allowed to look in the small channels. And what was found were debris, stain discoloration, scratches, channel shredding, moisture, everything, even in total normal and new endoscopes. And all endoscopes were concerned. Here you see the list: duodenoscopes, echoendoscopes, gastroscopes, and colonoscopes as well. They showed changes within the channels. So all conditions to make an adherence of bacterium load possible. So regarding these problems, the FDA and some other national authorities have implicated the national scientific organizations and the manufacturer to make changes in their behavior regarding reprocessing and the reprocessing protocols. They demanded a revision of the reprocessing protocol concerning duodenoscopes in total. They emphasized that information and permanent training for the personnel is crucial, and that special brushes, in particular for duodenoscopes, are necessary to eliminate debris in and around this area. The Olympus company and also Pentax, they proposed a mechanical check for all duodenoscope one time per year to look for mechanical stress and mechanical lesions in these areas to early eliminate all these instruments and not allow the bacterial transmission. And both companies have decided to renew the distal end design. So it may be that in the future we will have also again removable and autoclavable distal ends. For the clinical service, it is important to follow the new protocol and to follow the short time interval between pre-cleaning and cleaning. This interval should not be prolonged regarding to the cell division of bacteria, so keep it very, very close. There were some other attempts, moreover in the States, to look if sterilization procedures, cold sterilizations, for example, with ethylene oxide gas, should be possible. So the Chicago group tried to do it. And in Seattle, they tried to look for microbiological checks before the next endoscopic intervention. They took the endoscopes 48 hours in quarantine and waited until the microbiological answer was negative before the reuse. And another group around Douglas Rex, they made 2 reprocessing cycles in the washer disinfector to eliminate the germs. The first problem is the brush. Here you see the difference between the old brush and the new one. And the new one is the right to allow to brush all the areas with the small bristles around the albumin elevator and should only be used in duodenoscopes. Another progress is the new washer disinfector. In the old construction, there was a front lader, a standalone and integrated in under table, but the new one is the pass-through machine. See it on the slide here at the bottom. The pass-through machine allows a strict separating from a clean and unclean area, and it reduces the human error considerably. But what about the American studies? Douglas Rex tried to perform a double reprocess procedure on a high-level disinfection. This is the American term for the normal disinfection way, to eliminate the bacterial load. But in fact, there was a reduction, but not a complete elimination. And the bacterial positive cultures dropped from 9.4 to 4.8. And the dangerous germs were in a number of 0.8 to 0.2. That means a further step, but not a definitive answer. The Chicago group used ethylene oxide, but at the very end, there was no total elimination, and a carbapenem-resistant germ was found in 1 case, which was different from the New Delhi germ, which was first detected in this hospital. The other trial from Los Angeles is much more interesting. They did a permanent microbiological test, and they identified some endoscopes which were definitely unable to reprocess at the very end. What they did over a period of 2.5 years was to have permanent microbiological control. So you see the tremendous high number of cultures, more than 3,000 for duodenoscopes. And among these, 37 positive culture with MRGN bacteria were found. But the rate was decreasing. It dropped from 2% to finally 0.16%. And the reason for that was the detection and finding of 3 specific duodenoscopes which were unable to completely reprocess. all these endoscopes had removal of the Alber-Hebel channel elevator, and they were completely new. And this is the interesting sketch from this institution. Here you see the endoscopes in gray, in black, and in white. And these 3 endoscopes, among a number of more than 20, were the 3 who were not suited for further treatment. After eliminating the first, the gray one, the positive culture rate dropped down to a 1% rate. After that, they find a second endoscope, which was difficult to reprocess. This was the black one, and after eliminating this one, the rate dropped again. So finally there was here the white one, which gave the rest, and after eliminating the third one, the positive culture rate was getting to 0. Now this gives hope for the endoscope reprocessing for the future. So what to do after the tempest now, and how to get better? It is clear that we have to intensify and optimize the whole process and train our personnel, and that validation and regular requalification of washer disinfectors is necessary, as well as regular microbiological surveillance, but not of endoscopes only, also of the wash and disinfector, of the storage cabinets, of water supply, and the endoscopy room every 3 months. Personal training and qualification is mandatory, and the maintenance control of endoscopes and the progress in detail can be seen by the pass-through machine, by special process, and by the time management of the whole process. But one is clear: an absolute safety and a germ-free endoscope can definitely not be guaranteed. Thank you very much for your kind attention.